the whole panel, what are the future directions? How do we build on the success of this informative vedotin pembro regimen? Is it with triplet therapies up front, intensifying therapy up front? Is it with better, maybe second-line therapy, some form of better maintenance after EV?
I think what we need to really do is understand resistance to enfortumab vedotin, right? So 70% of patients respond, about 40% of patients have long-term durable responses. So why are they responding? Why are the other 60% not? There's some data that suggests that Nectin-4 is preserved after treatment with EV. So maybe the resistance is not because you lose the Nectin-4, surface protein, but maybe it's resistance to the drug. Maybe there's other ways. Maybe it has to do, remember, this is an ADC, there's a linker. So if there are other mechanisms at play that may inactivate the ADC, I think that's going to help drive a lot of this development that's so exciting. We have so many trials coming in. But that would really open the door to other agents that target Nectin-4, either small molecules, CAR T cells, bispecific engagers, radiopharmaceuticals. There's really so many ways to go after Nectin-4 now that have shown success in other types of cancer. So I would just throw that out there as we sort of pick our favorite, next therapy. I think it's a call to action to really understand why EV stops working.
For sure, I agree with you, and Karine, I want you to comment too, but I think that's a big gap, right? How do we understand mechanisms of resistance? I think neoadjuvant trials can help us in this, to your previous point, Terry. If you have to URBT and cystectomy tissue, can you tease out some biomarkers, some hypotheses? If you do biopsies at metastatic disease after progression on EV, even in your practice, I think that will generate a potential database to look at this tumor tissue at the time of progression. And of course, ctDNA, can you tease out some potential, genomic landscape alterations that may be relevant, because we do not know. Is it Nectin-4 loss? It has something to do with the influx or efflux of the drug, something with microtubules. We need to tease this out to facilitate drug development post-EV in metastatic disease. And then to your other question, I think there are two different strategies in the frontline setting to build up all pembro EV. One is what Guru started with Brad McGregor. Do you combine ADCs together, and can you potentially add an IO in that context? And I think there's a trial DADIO being designed in that context. Or you take the approach of maybe less toxicity, but adding another checkpoint or immunomodulation. And you can do a pembro EV plus an IO, another immuno-oncology compound. I don't think we know the answer, but I think exploring both pathways may be relevant.
Yeah, I think there is a study ongoing right now, the Keymaker UO4, which is looking at EV pembro with LAG-3, which we've seen has reduced toxicity, but still good efficacy in melanoma. So we'll see how that translates to bladder cancer. And then also TIGIT is another immunomodulatory drug that may be of interest in this space. So it'll be exciting.
Yeah, I think there's a lot of future compelling data that will come out of future conferences, and a lot of course, compelling data at this conference.
Sure.
And
yeah, I was also just going to add, there are neoadjuvant studies going on right now, including studies of EV plus pembro, the 304 trial, which may move a lot of these therapies. We're talking about EV pembro as the frontline treatment, but it may be that we're giving this neoadjuvantly, and that's really going to open up the metastatic space. If patients relapse despite that, do you retreat? Maybe patients will be neuropathic. So we have to, on top of understanding Nectin-4 biology, we also need to think about new targets, TROP2, HER2, FGFR. Those are the big kind of elephants in the room. What's next, And that's just years to come.
Undoubtedly a dynamic treatment space, and a lot of, it seems like every conference we have better options to offer patients, which is, amazing. And,
very exciting.
Yeah, I think we've come a long way, and but still a long way to go, of course. Yeah. And with that, again, I want to thank everyone for their contributions. It's been a great discussion, and look forward to future ones.
Thank you.
Thank you.
Great.
Thanks for